Welcome to everyone. Thank you for joining us. I see we have a great turnout. My name is Ann Dodge, nurse practitioner and senior care navigator for the Family Heart Foundation. I would like to welcome you to our Family Heart Foundation Pediatric Lipid Screening webinar titled, Why Do Guidelines Recommend Universal Screening for High Cholesterol in Children? We are so pleased that Dr. Amy Peterson from University of Wisconsin is joining us for this presentation. Next slide. Just a little information to share. Information in this webinar is for your information only. This content is not intended to be a substitute for professional medical advice, diagnosis, or treatment, and does not constitute medical or other professional advice. Medical information changes constantly, so information in this webinar could be updated or changed. Please follow up with your doctor and medical team for specific recommendations pertaining to the treatment of you or your family. Next slide. Feel free to use chat to introduce yourself and where you are from. Please use the everyone setting when introducing yourself so we can all see it. Next slide. We welcome your questions. If you have questions, please enter them in the Q&A area below to the right of chat. I will be tracking those questions and will direct them to Dr. Peterson at the end of the webinar. We ask that you please keep questions generic and not about a specific person or case, since we cannot provide direct medical advice. Next slide. I would like to thank our generous corporate sponsor, Regeneron, and Family Heart Partners for the 2024 lead for Pediatric Cholesterol Screening Initiative. Next slide. I now have the honor of introducing our speaker, Dr. Amy Peterson. Dr. Peterson is a pediatric cardiologist and director of the Pediatric Preventive Cardiology Clinic at the University of Wisconsin School of Medicine and Public Health. We are very pleased that she also serves as a scientific advisor to the Family Heart Foundation. Her research spans many areas of pediatric lipidology, including universal screening and implementation of universal pediatric screening guidelines. Welcome, Dr. Peterson.
I'm so excited to be able to join everyone. So tonight, I just want to speak with you a little bit about why we should get our children's cholesterol checked. So as a parent, as a grandparent, as a caretaker, why do we want to do this? And so I just want to take a little step back and explain just what is cholesterol. And so the way I explain it to families is that cholesterol is this fatty stuff that floats around in your blood. And we all need some of it actually for our body to work properly. We think of cholesterol generally as this bad thing, but we actually need some of it to work. So it's an important part of the membranes of our cells, and we also use it to make hormones as well. And unfortunately, though, what can happen is when we have too much of it in our blood, it builds up over time. And so that can lead to clogs in our arteries. And if that happens in the blood vessels going to your brain, that's a stroke. If it happens in the blood vessels going to your heart, that's a heart attack. And we generally think about cholesterol being in foods that we eat or related to our diet. So if you're from Wisconsin, like I am, we all think of a good meal at Culver's as a good source of cholesterol for ourselves. However, for most of us, most of the cholesterol in our body is actually made by our body. It's made in the liver, which is an organ in our belly, and a percentage of it is consumed as a part of the food that we eat. And this cholesterol doesn't really mix or dissolve in the blood. And so it gets packed up with these other things called triglycerides and some proteins into these lipoproteins, which are basically little circles of fat, cholesterol, triglyceride, and protein that float around in our blood to deliver it to where it needs to go. So the reason why we would even think about checking cholesterol in children, because I think some of the problem starts with we think of high cholesterol as a problem that adults have or something that happens when we get older. And that is true, but we know that high cholesterol can run in families. And so one of the most common forms of a significant cholesterol elevation that exists is something called familial hypercholesterolemia, which is a big mouthful. So we usually just call it FH for short. And what it is it's an inherited condition where there's a lot of the bad cholesterol, the LDL cholesterol in the blood, and it's present actually from birth. And we know that if it's left to just build up over time, it can lead to early heart attack and stroke. So it's caused by mutations in our genes. And so we know that a parent who has FH can pass it on to their child. And whether or not that FH gets passed on to their child really has nothing to do with how healthy you eat, how much exercise you get, or your weight. There's a lot of focus on high cholesterol being associated with people being overweight, and that is not the case with FH. And people who have FH, it's important for them to eat healthy and exercise, but they almost always need medication to help lower their cholesterol to the levels where we need them to be. The reason we care about finding high cholesterol in children is because what we want to do is we want to stop that accumulation of the high bad cholesterol really before it gets started, and it can actually cause heart problems. So this is kind of a busy diagram, but I do think it's really important. So if you guys can see my mouse here, what this is showing is the act of this LDL cholesterol, the bad cholesterol, building up in the blood vessels over time. This is the accumulation of cholesterol in the blood. And then on this line, you can see this is what happens as people get older. So if you take someone in just kind of in the general population who doesn't have FH, just like your average person walking down the street, you can see that cholesterol builds up over time. And then up here, they start to cross this line here in green, which is where we start to think about now there's been enough cholesterol exposure in their blood vessels where now they're going to start having heart attacks, strokes, needing stents, needing bypasses. And so for a lot of people in the US, that can happen around 55 years old. So if you do things that we know are bad for you, like smoking, high blood pressure, diabetes, high triglycerides, low HDL, which is the good cholesterol, and this thing called lipoprotein A, that can actually lower that threshold and you can have heart problems at a younger age. So now what happens if you have FH? So if you have the more common form of FH, which is the heterozygous form, where you have one copy of a gene that is not processing the LDL cholesterol properly, and we just don't do anything about it, and you just keep getting older, what can happen is those people can start to have heart problems in their 30s. So there'll be this red line here. So now if we are checking someone's cholesterol when they're young, like let's say we check them when they're around 18 years old, they're becoming an adult. There's a lot of people who think that that's the best time to check cholesterol because they're about ready to become an adult. So you can do that. And that's great if you check it at that age and you start them on a high dose of a cholesterol lowering medication. What's going to happen is you start to bend the curve and then they become this teal colored curve. And they, instead of that heart problem happening at 35, it might start to happen at 48. But if we start a little bit earlier and we actually start them on a low dose of those cholesterol medicines right around 9 to 11 years of age, and you're going to see that number again, then what happens is we start that drop even younger and they become this kind of purplish bluish line here. And they'll start to cross the threshold into heart disease around 53 years old, which is not quite as good as 55, but we're getting pretty darn close at that point. And then we have this group of people who have the more severe form of FH, homozygous FH, where they have two copies of the gene that don't allow the LDL cholesterol to be processed properly. And those people can actually develop heart problems in childhood. And this model shows it happening at about 12 years old. However, people are like, okay, that's nice. What happens in real life when we actually have people with FH who are taking these cholesterol lowering medications? So that study has actually been done. So this is data from, this is from a group of people in the Netherlands who have been taken care of, where families are taken care of with FH from a very young age. And what we have here is we have two groups, which I call them the children and the parents. So we have parents here who started taking these cholesterol lowering medications as a young adult. They weren't available when they were little. And so they started taking them in adulthood. And then we compared them to their children who were able to take those medications from childhood. The average age was about 14 years old. So they had that extra decade of treatment with the statin medications to help lower their cholesterol. And you can see here what happens. This graph is basically, you move down on this graph as people are having heart problems. So look at this. These kids, they're now 40 years old, and that is pretty much a completely flat line. No one's had a heart problem. But if you look at their parents who started the medicines on average 10 years later, you can see they're starting to have heart problems. So people ask me, what's the problem with waiting until 18 to check? And I'm like, well, I'd rather they be checked at 18 than not at all, but it's really not as good as checking it when they're younger. So when you look at these people at 39 years of age, almost all of the people who we called the children had no heart problems. But by that point, 26% of the parents with FH had a heart problem. And unfortunately, 7% of the parents had already passed away from their heart disease. So we know that so we're like, great, that's awesome. Let's find the people with FH. Let's screen them when they're younger, and let's get them all on treatment. The problem is we know that we're not very good at figuring out who has FH. We're not very good at finding it. And we think about 10% of the people in the US who have FH actually know that they have it. And a lot of those people, even if they know they have it, it's hard to keep their cholesterol levels at goal. And I hate numbers. I hate making people feel like they should memorize numbers, but there's two that I would like you to remember. So if you are a child, if your LDL cholesterol, or excuse me, if you're 20 years old or younger, if your LDL cholesterol, that bad cholesterol, is 160 or higher, someone should really be wondering if that child has FH. There's probably about a 50-50 chance that they have FH. But if you have a child and their LDL is over 190, there's about an 80% chance that they have FH. And that's before you've done any other testing, you've asked any other questions, you've asked about their family, any of that kind of stuff. It's just looking at a cholesterol panel. So what we used to do back in the day was we were asked to screen children if they had risk factors for high cholesterol. And we should still do this if we have a child who has risk factors. But we used to focus on only screening children who had risk factors. So what we would do is the recommendations were that you would screen a child if they had a family history of someone with high cholesterol, if they had a family history of someone who had heart problems at a young age. And we usually say a male relative under 55 or a female relative under 65. Or if you didn't know the family history, like let's say the child was adopted, for example. And you would want to screen if that child themselves had overweight or obesity, if they had high blood pressure, if they used tobacco, or if they had diabetes. So these were children that were thought to be at high risk or at increased risk for having high cholesterol. So there's a few problems. It's a beautiful theory, but it starts to have problems really quickly. Like, I don't know if everyone here has children, but you've probably been in a doctor's office for like a well visit, and it goes really fast. And there's lots of things that the doctors have to do really quickly to get through their list. So that is kind of a big clunky list of risk factors for someone to have in their head and be able to kind of go through them and figure out who's at risk. And even telling what the risk factors are can be tricky. I'm old enough that I have been a doctor before people had access to like patient portals and could just sit and pull up their lab results. And so there's a lot of parents who either just have not had their cholesterol checked or have had it checked and don't really know what it means or weren't given accurate information about their cholesterol panel. So they can't tell you my total cholesterol is over 240, like they just don't have that information. And we take care of a lot of people where we don't have access to the health information from one of the parents for whatever reason. Either they're not involved or and sometimes it's even something simple as like, well, that side of the family doesn't really talk about their health at all, so I don't know what's going on. Or that side of the family lives in the old country and they don't have access to preventive care, so we don't know if they have high cholesterol. We can also have situations where parents and grandparents may be younger, so they're not like old enough to have really had a heart problem yet. So for example, if a grandmother is 55 and she hasn't had a heart problem yet, I'm very happy about that, but I can't necessarily use that information to tell me that there's no family history of early heart disease. It just hasn't had long enough to develop yet. And so what's happened is there's actually been a study on this. Well, like what happens why don't we just check everybody then? What happens if we just check all the kids regardless of their risk factors? We just check them. And so that study was done. It was done in 2010 in West Virginia, which has very high rates of heart disease. And what they did is they looked at 20,000 fifth graders. And so what they did is they sent these kids home with a questionnaire that basically asked the same questions that I showed you on the previous screen. But then what they did is they just checked them all anyway. They checked their cholesterol anyway. And what they did is when they looked, first of all, 70% of the children would have would have had a risk factor that should have meant that they were screened. And I think if we're finding that many children would have a risk factor anyway, I don't know, it just seems a lot easier to just go ahead and check everybody. The other thing you're going to see here, if you're looking ahead, is it didn't really matter. So the percentages of children who had high cholesterol was basically the same, and actually it was a little bit higher in the group that didn't meet the screening criteria. So you had 8.3% of children with high LDL in the group that met screening criteria, but you had 9.5% of the children in the group that didn't meet screening criteria. And then if you start looking at, gosh, is this maybe FH? Do we have to think about medication? You see again, the rates are similar in both groups. And again, we're actually higher in the group that didn't meet screening criteria. So some things to take away from this, in addition to the fact that most kids have some criteria to get screened anyway. Another point I want to make is that thankfully we don't have to use cholesterol lowering medication in children very often. Some people get this idea, we're just trying to check every kid's cholesterol so we can just put them all on medicine. And that's just not the case. Most children don't need medication. Most of the children who need medication are actually kids who have FH. And in this population, it was just over 1% of the children had an LDL cholesterol over 160, which is sort of when you would start to think maybe we need to use medicine. So thankfully, we don't have to use it that often. However, the thing to keep in mind here is that even if your doctor was like perfect in identifying every child who met these selective screening criteria, could pick out every kid with a risk factor, and they were able to do that, and nobody's perfect, right? But they still would have missed over a third of the kids who had really high cholesterol. And so then after this study came out, the AAP, which is the American Academy of Pediatrics, they basically said, yes, if you follow our guidelines, you're going to miss 30 to 60% of children with high cholesterol. And it's not because anyone's doing anything wrong, it's just because of those reasons that we said. So then what happened in 2011 is a new set of guidelines came out, and we call these the NHLBI guidelines, the National Heart, Lung, and Blood Institute guidelines. And the American Academy of Pediatrics has also endorsed these guidelines, meaning they think that this is the right thing to do. So you have to remember that this is looking at information that's probably 15 years old now. So I would probably do it a little bit differently now, but this is basically what the guidelines still say. They're in the process where they're going to be reworked in the next few years, but this is what we have right now. And the main one here that I want to draw people's attention to is this was the first guideline that actually recommended that all children get their cholesterol checked between 9 and 11 years old. And it's for the reasons we just talked about. It's because we're not going to pick up everybody if we just screen at-risk children. And we want those kids who have FH or other severe cholesterol problems to be able to start medication young enough that it's going to really effectively prevent the heart disease. The other things to kind of look at here is for the other ages. The main thing is you still want to screen children if you find them who are at risk for high cholesterol. So this would be kids who have a family history of high cholesterol or heart disease or have one of those other health conditions. Now, at the time this guideline was announced, there was basically no recommendation for screening in children younger than age 2. However, with the current modern medications that are available, I think if there is a very strong family history of early heart disease, I think you can make a good argument to screen children younger than age 2. So when you go and talk to your child's pediatrician or their healthcare provider, they may say something along the lines of that testing kids' cholesterol is not recommended. And so what they are probably referring to if they say that is there is another organization called the U.S. Preventative Services Task Force. And what the U.S. Preventative Services Task Force does is it's a group of volunteers who are experts in prevention, who look at all sorts of preventive health measures for people in the United States. So they look at like mammograms for breast cancer and colonoscopy for colon cancer, and they look at all sorts of things. And what they do is they give each recommendation a grade, and they grade it based on the strength of the evidence supporting it. But they have very specific definitions of what is considered strong evidence. And it's important to note too, they do not consider cost in this at all. They're just looking at the evidence and the balance of the benefits and harms. And so what they do is they'll give things a positive recommendation, or a negative recommendation saying, don't do it. Or oftentimes what they do is they give something an I recommendation, and I stands for insufficient. And so the idea of checking every child's cholesterol got this I recommendation, which basically they're saying there's insufficient evidence to recommend for or against the screening measure. So then what happens when something is given an I recommendation is they're asking the healthcare provider to review the evidence for themselves and make their own decision about whether or not they want to actually do that preventive measure and take into account individual patient factors. And that's a good idea, but in practical considerations, it's a huge ask for very busy healthcare providers because lots of things get I recommendations. And so very often, many healthcare providers look at an I recommendation and they kind of take it as a don't do it because there's not good evidence to support it. So they kind of almost consider that a negative recommendation when that's not the intent. And so just to give you an idea, there's a lot of things that actually get an I recommendation from the U.S. Preventative Services Task Force. So it's not just cholesterol. And here are a few that are listed. Many of these things are things that the American Academy of Pediatrics has recommended as good things to do for children. But again, they've gotten that I recommendation from the U.S. Preventative Services Task Force. So it doesn't mean don't do it. It just means it doesn't meet their standard of evidence. However, universal cholesterol screening in children has been endorsed by many other organizations, and you can see some of them listed here in addition to the Family Heart Foundation. So some people will ask, okay, so I get my kid's cholesterol checked. So what does a typical cholesterol panel of a child with FH look like? So this is actually, it's an older panel, but this is actually a child I take care of in my clinic. And you can see here some numbers on the panel. This is what happened when the child first came to see me. So you can see here, the total cholesterol is high. So usually 170 or lower is normal. And you can see this triglyceride number is at 119, which is a little bit high for a child, not too high. That HDL cholesterol, the good cholesterol, looks normal here at 49. That's a great HDL. And then what really stands out to doctors would be this LDL cholesterol, the bad cholesterol. In this case, the child's LDL was 202. So this is basically, this is FH until proven otherwise. But you do have that kind of pesky triglyceride that sometimes is distracting to some doctors. They think that if there's a little bit of high triglycerides, it doesn't mean that they have FH, and that's just not true. So a lot of people will also ask, okay, so my child has FH, or my child has high cholesterol for another reason. And we're talking about medication, but there's a lot of misinformation on the internet. So like, what are some healthy lifestyle things that we can actually do? And in this child, I would actually recommend, in addition to medication, they do these healthy lifestyle things, because I think that's the best way to help the rest of their panel stay healthy and the rest of their body stay healthy. So these are just some recommendations that we will typically give for everybody. And I know sometimes I struggle with these in my own life too, but we talk about listening to your body's hunger cues and respecting it when you're hungry and respecting it when you're full. Cutting out sugar sweetened beverages. So avoid the liquid sugar and drink lots of water is really helpful as well. Eating a high protein breakfast and really avoiding distracted eating patterns. So turning off screens while people are eating. Oh my gosh, the number of times I see people on a phone while they're eating a snack. And then also making sure sleep is good and give your screen a bedtime as well as your child. And then really just any kind of movement, any opportunity to get up and move and be active, ideally with something they enjoy, is a great idea. So really some take-home points here. The main one here is that the purpose of cholesterol screening in childhood is to identify and treat children who have genetic forms of high cholesterol that are raising their risk for an early heart attack or stroke. There's a lot of kids who are going to end up having mild elevations in their triglyceride, which may be related to the kinds of foods they're eating and the kind of exercise they're getting. And that's great if you can find those kids and help them lower those things, but through a healthier lifestyle. But really the point of this screening is to find those kids who need more than just healthy eating and exercise. They probably need medications and they need their family looked at as well. And again, a lot of people confuse childhood obesity with childhood high cholesterol. They're related, but they're not the same thing. So the kids who have high cholesterol that's related to having obesity or not eating a healthy diet or getting enough exercise, those aren't the kids that need the medications. And I would say usually that's true because we see so many kids now who have obesity that I see plenty of kids coming into clinic who have FH and obesity just because it's so common. So it's not, it doesn't protect, one doesn't protect you against the other. And just because you have one doesn't mean you have the other. And then the third point is, if you don't check for high cholesterol, I guarantee you can miss high cholesterol. You know, I'll tell all my patients, you know, high cholesterol doesn't make you look sick. It doesn't make you look different. It doesn't make you feel sick. The first sign of high cholesterol, unfortunately, can be a heart attack or a stroke. And the other thing I tell the families is, you know, I never think of finding a child with FH as I just found a child with FH. It usually means I found a family with FH. And a lot of times there's other members of the family who don't know that that's what they have. And then their child being diagnosed is what leads to them having their own diagnosis. So again, if we can figure out ways as a country and a society to effectively address heart health in children, that's probably the biggest opportunity that we have to improve the health of all humans. So thank you very much. I appreciate the time to talk.